Hey, hi.
We are live.
Good evening, everyone, and welcome to this presentation on nutrition care process in renal condition. And what a coincidence that we are having our World Kidney Day in the next 2 days, which will be 12th of March. And the theme for this year is living well with kidney disease. Um, so we have some objectives that we want to achieve today in this presentation, which is number one, be able to describe the 4 steps in the nutrition care process. And then we also, by the end of this presentation, will be able to understand the goals that are there in the management of patients with renal condition. And lastly, we would want to recognize the renal related labs and their goal values. So, what is renal disease? Renal disease or condition is defined as a decreased kidney function, or it is kidney damage for over 3 months, that is defined by a structural or functional abnormality of the kidney, with or without decrease in GFR, or if there's decrease of GFR over, like, which is below 60 mils per minute per 1.73 meters squared for over 3 months, that we term it as kidney disease. And this definition is from the KDIGO guideline of 2021. So there are several risk factors of the kidney disease, which are as follows. Number one, if there is a family history of kidney disease. Number two, if one has a history of high blood pressure, diabetes, cardiovascular diseases, among other risk factors. So we have, according to the GFR, the kidney disease or the chronic kidney disease is staged in different stages. When we talk of chronic kidney disease, we stage it from stage 1 to stage 5. When we talk of AKI, we have stage 1 to stage 3. And in different stages, when you talk of GFR, then it has different, when, for example, let's say, for example, when your kidney is normal, then your function will be about 90 and above. The GFR should be 90 and above. Then when you talk of one having kidney disease, then the GFR will be between 60 to 15. Then when you have total kidney failure, then you're talking of a GFR of 15 and below. So in the care process of this renal disease, of course, it will involve a multidisciplinary team, which includes, let's say, a nephrologist, a renal nurse, a renal dietitian, a pharmacist, a social worker, and also the relatives to the patient. So let's look at the nutrition care plan. So basically, what is nutrition care plan or a care process? So nutrition care process is defined as a systematic problem solving. It is a method actually that was developed by ADA, that the dietetic professionals should think critically, make decisions addressing the nutrition related problems, and provide a safe, effective, a highly qualified nutrition care. So there are several goals of the nutrition care process, which are: number one, to improve or preserve the nutrition status of a patient. Number two, optimize the function status of a patient. Number three, delay progression of the disease. For example, if a patient is in stage 2, you want to delay the progression of that disease to the end stage. Number four, influence and change the factors that contribute to an imbalance in the nutrition status, and therefore restore an improved state of nutritional health. Number five, we can have a goal where you want to prepare patients for transplant. And lastly, you also want to adjust the diet to cater for catabolic events that may come up. So there are several steps in nutrition care process. Actually, there are 5. And number one is the nutrition assessment. Nutrition assessment, basically, you look at the nutritional health status of a patient. Number two is the nutrition diagnosis, which in nutrition diagnosis, you want to interpret the data that you have. Number three, it's nutrition intervention, where you want to develop a plan of action. And lastly, it's nutrition monitoring and evaluation, where you monitor the effectiveness of the plan that you have intervened. So we start from the first one, which is nutrition assessment. So in nutrition assessment, it is where data is taken in order to make decisions about nature and cause of any nutrition related problems. So in assessment, it is a very systematic process that you want to obtain, verify, and interpret the data accurately so that you describe the problem, the nutritional problem, and so you at the end of the day, you will facilitate the formulation of a nutrition diagnosis, and which will now be the next step of after assessment of the care process. Assessment also provides a means to reevaluate the nutrition program as a part of nutrition monitoring and evaluation. So basically, assessment, it gives a basis on how the next step of diagnosis and the rest of the nutrition care plan process are going to be implemented. So in assessment, there are several things that we may want to look at. More so when we are looking at the renal conditions. When you talk of anthropometrics, you may want to look at the weight, pre-dialytic weight, interdialytic weight, post-dialytic weight. You may want to know the dry weight of the patient. And for that matter, it will help you as a nutritionist to know whether the patient is, taking too much fluid, or the patient is, having edema, or the patient is, not adhering to the diet using the weight alone. Another thing in the anthropometric is the height and the BMI, which will guide us to know whether the patient is having malnutrition. The next, in nutrition assessment, we want to look at the biochemistry, where biochemistry, you will look at the lab values. Take, for example, you may want to look at the full blood count, the UECs, which are very important in renal condition, the LFTs. You may want to look at the PTH, all that, the serum glucose, and this will help you in coming up with a nutritional diagnosis. And it is also very, very important for us as nutritionists to know the values, those that are within the reference ranges. Take, for example, when you're looking at the say potassium, the levels, you need to know the levels that are within the range. You need to know different lab values. For example, if you're using millimoles per deciliter for potassium, you may want to know that the normal reference ranges will be about 3.5 to 5.1, so that when you see the results of the patients, you're able to intervene well. Another component in assessment is nutrition focused physical exam. And this is also very, very important because it will show us the signs and symptoms of, let's say, fluid overload. If the patient is constipated, you look at the micronutrient deficiencies, maybe through the skin. You may also want to look at the fat and muscle wasting through the presentation of the skin. You may want to look at the tongue. How is this patient? The eyes, are they pale? So it is also good to also do the nutrition focused physical exams, since it will guide us in diagnosis, and also in other components of nutrition care process. Another component in assessment is diet history, so that when you are talking to a patient, you may want to assess how are they eating. You may want to use several methods. You may want to use 24-hour recall, or a food diary, or a food frequency questionnaire, so that this will help you to know the adherence of the patient to the prescribed diet. This method will, component of diet history will also help you know how the patient is preparing their food. Say, for example, you taught the patient how to leach. Are they adhering? Are they following the process? So it is very important. And so this diet history may also indicate the diet intake prior to maybe hospital admission. Did the patient have appetite? Are they eating well? Are they eating a balanced diet? It may also indicate the period in which maybe the patient was on NPO within the hospital, or even at home before they came to the hospital, when the patient took the last meal, and so on and so forth. And the last component in assessment is client or medical history of the patient. It is also an important component because it helps us to know about the medications or the drugs that the patient is using, when the disease began, the history of admissions. That will shed more light to know the intervention that you're going to take as a nutritionist. So number 2 is the nutrition diagnosis. Number 2 component in nutrition care process. So number 1, we've talked about nutrition assessment, and we've talked of 5 components. So the next one is nutrition diagnosis. So how do you come up with a nutrition diagnosis? Basically, nutrition diagnosis has a PACE format, which is a problem, etiology or the cause, and then the symptom or the sign. This format helps us as nutritionists to come up with a well prescribed nutritional diagnosis. So nutrition diagnosis is generally stated as the problem due to etiology, which is the cause, as evidenced by a sign or a symptom, or symptoms or signs that you may see that are presenting from the patient. So let's say, for example, let's take a quick example of how you can come up with a diagnosis. So a patient has voluntary weight loss, which is now the problem due to inadequate energy intake, which is the etiology, the cause. That is the cause of the involuntary weight loss, as evidenced by what? By maybe the patient has lost 8 kilos of weight within 4 weeks. So when you're stating your nutrition diagnosis, you want to follow the PACE format. You have to state the problem, the cause of that problem, which is the etiology, and any sign or symptom. Another example would be, let's say you've realized the patient has hyperkalemia. So your problem is hyperkalemia due to what? Maybe the patient, from the history, that history, from the first step, you've realized the patient took 1, 2, 3 things, maybe potatoes. And what is the evidence of hyperkalemia is through the biochemistry, which will show you the lab value of potassium. Maybe the potassium value will be 7.2, then that means the patient has hyperkalemia. So your diagnosis will come up with the problem, the cause of that problem, and the evidence. You have to give the evidence of your diagnosis. The third step is intervention in the care process. So how do you do nutrition intervention? Basically, nutrition intervention involves planning and implementing. So one should prioritize the nutrition diagnosis when you're planning or when you're intervening. So let's say, for example, your patient has come in and they have fluid overload, uremia, hyperkalemia. So how will you prioritize your intervention? So you look at the order in which the patients will be affected by the problems that they've come in with. So for me, what I'll start with is hyperkalemia, because hyperkalemia can kill the patient like immediately if they are not attended to. So you address hyperkalemia, and then you can go in order of priority. Then you can maybe address fluid overload, then uremia. So you should prioritize your nutrition diagnosis in your intervention. So then you should arrange your problems in order of importance and urgency for the patients and come up with ideal goals and the patient-focused expected outcomes, so that when you know you want to address hyperkalemia first, how long are you intending to address this? What is your problem? What is your goal? And are the expected outcomes realistic? Okay, so implementing the intervention that you've made then would be the next step. And then in monitoring and evaluation. So in monitoring and evaluation, you determine the degree to which progress is being made and whether or not the client goal or the desired outcomes of the nutrition care are being met. So that when a patient, for example, comes in with hyperkalemia and say it's not too high, maybe it's 5.7, and they've gone for dialysis, then you want to probably do a nutrition counseling and talk to them about the foods that are high in potassium, so that they can limit their intake, so that when do you expect your desired outcome, your goal, when do you expect to meet this goal. So you put a realistic a realistic goal that you will, of course, achieve. So in management of renal disease, there are goals that we need to meet, as you've said. And these goals, like in renal disease, there are, like we said earlier, there are several diseases. We may talk of AKI, we may talk of CKD, nephritic diseases, but these ones, they have goals, and in your goal you want to emphasize on avoiding the metabolic problems that would probably say particularly relate to excess dietary protein or phosphorus and other components. They are not only proteins and phosphorus and other many components, which you may also want to look at: proteins, potassium, calcium, fluid, vitamins, and minerals. And it is also very, very important, as we had said earlier, to know the reference ranges, where it will help you to know your intervention. Let's talk about protein in management of renal disease. As we all know, protein is the backbone of the diet. It is essential for growth, for muscle building, boosting your immunity, preventing infection, and many other things. So proteins also are measured as albumin in the blood, and there are several importances or there are several things that albumin do in the blood, which we know, of course, like in maintaining the appropriate osmotic pressure within the blood, binding and transporting nutrients, substances like hormones, drugs. So protein is a very important component in managing the renal disease. We also have calories in the renal diet, and usually patients may have poor intake of calories, maybe due to frequency of illness or hospitalizations. These patients may have GI problems, constipations, maybe due to medications. Their age also may matter. Lack of exercise is another issue that may make these patients to have, inadequate calorie intake or poor appetite. So there are several suggestions that you can give to a patient to encourage them to have adequate calorie intake. Which one is, you may encourage the patient to not at least miss meals even when they are not hungry. Let them take small frequent meals. If a patient is eating poorly and they have, and their potassium or phosphate are low, you can, rebelarize their diet. When the patient has dysgeusia, where they have altered taste, then you can try and give them something like eggs, which will be more tolerated than, meat and all that. You may also want to consider giving them zinc supplements, and also you may want to consider serving proteins of high biological value. So let's look at the medical nutrition therapy in several cases, like when the patient is not on dialysis yet, when the patient is on dialysis, when the patient is preparing for transplant, because it is through this medical nutrition therapy that will help us intervene, in management of these patients. Say, for example, you have a patient who has AKI. There are several goals in maybe your diet. You may want to give this patient about 25 to 35 kilocalories of energy per kilogram. For protein in AKI, you want to give about 0.8 to 1 gram per kg of, that is the patient without dialysis. Patient who is on AKI and they are on dialysis, you want to increase their protein, because they lose the protein through the process of dialysis, so they lose quite a lot. So you want to increase their intake to about 1.21 to 1.5 grams per kilogram. So for fluid, basically you want to look, so for AKI, you want to see, does this patient have edema? If the patient has edema, then you want to limit their fluid intake to about 24-hour urine output plus maybe 500 mils only of fluid. So for sodium and potassium, you want to give about 2,000 to 3,000 milligrams. So for phosphorus, about 18 to 15 milligrams per kilogram. And for phosphorus, you may want to consider, if the phosphorus is quite high, you may want to consider giving food with the phosphate binders. All right, so we go to CKD, which is chronic kidney disease in stage 1 and 2. Stage 1 and 2, basically, there are not much restrictions. the patient's protein need would be normal, 0.8 grams per kilogram per day. The calories as well, 30 to 35 kilocalories per kg per day. For sodium, normal use, potassium as well, phosphorus too, unless the patient is starting, to have elevated, sodium levels or potassium levels or phosphorus levels. For fluid, again, you won't limit unless the patient is having edema. Stage 3 and 4 of CKD, the protein is normal, 0.8 grams per kg per day. Calories as well, 30 to 35. Sodium, you want to give 2 to 3 grams per day. Potassium, you want to give the normal levels, 2000 milligrams, unless the patient is hyperkalemic. Phosphorus, about 800 to 1000 milligrams per day. So for calcium, you want to give about 1.2 to 1.5 grams in stage 3, but in stage 4, you want to give more, about 2000 milligrams. Fluid, you give normal unless the output is less than a liter. So if the patient is on hemodialysis, the energy requirement will be guided by several factors, which will be, you want to look at their age, their physical activity, their weight status, and basically you will want to give between 30 to 35 kilocalories per kilogram per day. Protein in hemodialysis, you want to give about 1.2 grams per kilogram per day of high biological value. And so we prefer proteins of high biological value. Sodium would be about 2 grams per day. That is basically a normal, range. So you also want to advise the patient to change their lifestyle, their dietary modifications to recommend so that they may reduce the risk of cardiovascular diseases in chronic kidney disease. For potassium, you want to give about 800 to 1000 milligram per day. And we also want to advise on how to reduce potassium intake. You need to show the patient the foods that are high in potassium and fruits as well, so that they may reduce their intake. Phosphorus, when the patient's GFR reduces about below 60 mils per minute per 1.73 meters squared, then you want to restrict, but otherwise advise on limiting foods that are high in phosphorus. So phosphorus control aids in prevention of secondary hyperthyroidism, renal bone disease, and soft tissue calcification. Phosphorus and calcium with PTH hormone goes hand in hand in preventing renal bone disease, so that when your phosphorus is high, then you want to limit foods that are high in phosphorus, or give phosphate binders with meals, so that the patient may not have the renal bone disease. So for calcium, we should not exceed the 2000 milligrams per day. And calcium concentration is very important in regulating parathyroid hormone secretion, so that it may not affect the bone integrity and the soft tissue calcification. For vitamins, we all know that the water-soluble vitamins are dialyzable. So it is important to individualize the need as per the patient. So you may want to give calcium, you may want to give zinc supplements, vitamin D3, and these supplements, they need, patients should be advised to take them with the supervision of a physician. So when you're preparing your patients when the patients are on hemodialysis, they are being prepared for transplant. And when they've been transplanted, then the requirements change depending on the acute and chronic phases of the kidney transplant, where you want to give energy of about 30 to 35 kilocalories per kilogram. And this can be adjusted to suit the desired body weight during the chronic phase. So that you may find patients who are in the chronic phase, they may want to, reduce their calorie intake because of maybe they've gained quite a lot of weight. So for protein, in the acute phase, you give a high protein diet, which is about 1.3 to 2.0 grams per kilogram, because the patient has been transplanted, the wound is still healing, so you want to give more protein. And when now they come to the chronic phase, when the wound has already healed, you want to reduce the protein intake to about 0.8 to 1 gram per kilogram. For carbohydrates, it is advisable that we advise our patients to limit their intake of simple carbohydrates and emphasize on complex ones. They should also check their portioning and distribution. For sodium, you want to restrict if the patient has hypertension and if the fluid status dictates otherwise. So for sodium, you want to give about 2 to 4 grams per kilogram per day. Potassium, you want to give about 2 to 4 grams. And if the patient is hyperkalemic, if the graft has not, come up well, and the patient is hyperkalemic, then you want to restrict further the intake of potassium. For calcium, you want to give about 1200 to 1500 milligrams. And for fluid, you want to limit it by graft function. Otherwise, you don't restrict fluids if the graft has come up well. So for malnourished patients, there are several factors that you may want to consider in choosing the supplements. And this malnutrition in CKD is a big issue, and so we want to use a tool like, for example, the SGA tool to rate the malnutrition within which your patient is in. So there are several factors that you want to consider. Maybe how is their current oral intake, how are their recent lab values, do the patient have other comorbidities, how is their body weight, their fluid status, the recent change in their health status, and also the patient's preference also matter quite a lot. So in the nutrition care process, as we've said, we need to look at all that. And also, for you to intervene well, you need to know the medical nutrition therapy in each condition. So we should be well conversant with different renal conditions and their therapies, so that we may be able to intervene well. And for us to understand better, we have a case study where we have a patient who is male, and upon visits, the differentials showed hypertension and end-stage renal disease. And their current diagnosis, of course, is now the end-stage renal disease secondary to hypertension. So, patient comes in with complaints of severe headache, weakness, lack of appetite, dizziness, and the patient started their disease patient came in on September 16th, 2021, and he started experiencing the severe headache and some little weakness, which prompted him now to come to the hospital. And when the vitals were taken, the BP was quite high, 206/110. The patient reported that he had not eaten anything that morning, and the last meal that was taken was dinner. The patient has no history of alcohol or smoking, but they have a history of chronic disease in the family. The patient's vital signs were blood pressure of 206/110, pulse of 80, SpO2 94%, and temperature of 36.8. When history was taken, the patient started falling ill sometime back in 2013, and the patient was diagnosed with hypertension, and they did not adhere to the medications that they were given. So the diet history is that the patient took an orange and some little spinach over dinner. And so the labs, the biochemicals showed that the patient had urea of 39.2 millimoles and a creatinine of 1600, sodium of 140, potassium of 5.8, a chloride of 107, and a HB of 9. The nutrition focused exam showed that the patient looked dull and weak, and there was no presence of edema. So that is the assessment part. So when you go to diagnosis, our patient is hyperkalemic due to the end-stage renal disease, as evidenced by high levels of potassium, of potassium. And the symptoms that the patient came in were, the exhaustion, lack of appetite. Another nutrition diagnosis is uremia due to ESRD, as evidenced by high urea levels showed by the lab values of 28.28 and a creatinine of 1451. So what is our goal? Our goal is to, achieve total adherence to the renal diet guides, to reduce the amount of waste in the blood in the next, say, 1 month, and then to try and bring down the potassium levels within the normal in the next month. So our intervention is nutrition counseling to be done to restrict potassium-rich foods, which includes the orange that the patient took and the spinach, which explains it all. And then the patient also counseled to limit protein intake and encouraged to take proteins of high biological value. Since the patient has no appetite, patient is encouraged to take small meals frequently, and also patient counseled on the DASH diet because of the hypertension. So when you're doing your monitoring and evaluation, you want to look at your goals. So the number one goal would be potassium, which the goal can be partially met or fully met depending on the values that you want to look after maybe a month. So say after 1 month the potassium was 5.3 from 6.0, so that the goal will be partially met, because of course the potassium has not come back to the reference ranges, but at least it has reduced. You also want to look at your creatinine and urea. So you may want to say that you have also met your goal partially, because the potassium levels after a month, they came down to about 22 from 28, and your creatinine came down to about 1200 from 1600. So basically that is your monitoring and your evaluation. And so you also need to come up with a follow-up plan, which will be, maybe you want to see the patient in the next dialysis session and see if the patient has started eating well. And so another nutrition review will be maybe in the next 1 month. So you want to come up with a comprehensive care plan, and at the end of the day, you want also to follow up the patient and see how the patient is doing. So in essence, what you are saying, when you're monitoring the nutrition status of patients with renal conditions, you may want to assess them frequently, say quarterly, using a tool of your choice, maybe the SGA tool. And you in the medical nutrition therapy for the chronic kidney disease, we need to start from stage 3, where the GFR is below 60 mils per minute per 1.73 meters squared. So you want to intervene nutritionally at stage 3. And in nutrition care process of the renal condition, one should always ensure that the patient has the best possible health. You maintain the blood chemistries within the normal using your diet. If the diet is not playing a major role there, then you also want to look at other possibilities with the nephrologist and the renal nurse to know whether the dialysis is adequate. And then also in the care process, you also want to reduce the risk of morbidity for the patients. Thank you so much. That is my presentation for today. If there are any questions, you're welcome.
Thank you, Priscilla, for that wonderful presentation. And I'll ask you to invite your fellow panelists, and then you can have a panel discussion. You can be able to discuss the topics of areas of interest, which includes when you're talking about diagnosis, what are you looking at? The problem, the etiology, the science. You can be able to look at that. What forms of intervention can you be able to employ? We have a number of them, so we need to at least get to hear what interventions sometimes we're looking at. And when you're also looking at the assessment in the laboratory, there are certain things that would be able to alert the caregiver that these are red flags. What do the nutritionists need to look at in terms of the care process? So I'll leave it to you so that you can be able to welcome your fellow panelists and have a discussion.
Okay. Thank you, Milan. So, you're most welcome, Penina, Susan, Effie. Who's this? Laureen. You're most welcome. We can take it from there in more discussion on the nutrition care plan. Effie. Who's around? Susan, Lauren.
Thank you so much, Priscilla. That's a well articulated question. My name is Susan. General nutrition care process. It's like a process like any other we deal with in nutrition management. Where generally we start from the anthropometric, dietary management. We take the history of the patient. Generally, these are the major indicators which help us to understand which are the major nutrition diagnosis to give to the patient. Without these indicators, I think managing a patient could be so hard. And I think Priscilla, you have articulated your issues so well. You have discussed and even given a case study of the same for the audience to understand what is the nutrition care process. I don't have much to add on the same. I think the audience have seen what you have given out. More you have emphasized on the issues of the diet. Those are the major things in the management of the renal disease to a nutritionist or to the patient we are dealing with. They bring a lot of issues. Thank you so much. And I give room to other people who have something to add. They can add. Back to you, Priscilla.
Thank you, Susan. Anyone else who wants to add something on intervention or any other component of the care process?
Hello, hi. My name is Moralerin. There's something I'd want to add about the assessment process. I don't know if you already talked about it, but I'm going to say it anyway. There's this aspect of socioeconomic history. I believe it's a very important bit of the assessment part because this is when you get to know if your intervention is actually going to come to be, like you're telling your patients to have high biological value. Is your patient able to afford that? Yeah, because if you tell your patients just to take whatever you want them to without having a background check of affordability, of availability, and stuff like that, you might not be able to reach the end goal. Coming about to the patient might even tell you they have taken it, and that they didn't in fear of, well, you are not aware if they can afford it, if it is available. Um, that is one of the things that I didn't hear about. That's it for me. Thank you.
Thank you, Lauren. Anyone else with something to add on?
Hello.
Oh, there's someone on the other end?
Yeah, let's take Effie then, or Evelyn. Evelyn, you
Oh,
can go ahead.
let me continue. Um, good evening, everyone. This is
Good
Evelyn
evening.
Mwalo. I would like to thank the facilitator, that is Priscilla, for the recommendable job. Your presentation was well articulated, and you are able to explain more on the points that you are giving out. I would just like to add on one thing. When we are doing a nutrition care process or maybe the interventions, let us do we individualize the interventions. Let's not do a blanket recommendation. For example, we have different patients with different symptoms and presentations of their things. So if maybe someone is having a CKD and maybe they presented themselves with hyperkalemia, let's not maybe presented with maybe hypokalemia. So you don't need to restrict on maybe the potassiums, but work on the managing the hypokalemia. If they have hyperkalemia, work on the restrictions or limiting things that are maybe making the patient have hyperkalemia. So, good job.
Thank you, Eve. That is a very good point to note. In nutrition intervention categories, we actually individualize approach. We use individualized approach to care, so that whether it's food or nutrients delivery, you want to take each patient by themselves and not a blanket care, as you've said. Thank you so much. Anyone else? I'd wish to give maybe 4 nutrition intervention categories, which I want to believe maybe they didn't come out clearly. The first one is the food nutrient delivery, and then nutrition counseling. Then there's nutrition education and coordination of nutrition care. As we had said, the care is not I cannot take care of the patient alone as a nutritionist. We need other team members to come in to take care of this patient. So intervention, we need a coordination of the care, plus also the relatives also. They may want to, be given the nutrition education, nutrition counseling, the food and nutrient delivery. So those are the major 4 components in intervention. Okay. Anyone else? Any questions from the audience are welcome.
I think they'll have more questions as we continue presenting throughout the week. And being today was the first day of our presentation, maybe Yeah, so that's a good job there.
Thank you, Evelyn. So, Milan, maybe you want to guide us from here?
Okay. So tomorrow we are doing hemodialysis by Effie. I think I will say thank you for the wonderful presentation. Let us look more into these activities as we go on. And I want us to be able to mobilize our friends to be able to participate in these live discussions starting today as we roll. Thank you. We'll discuss the others after this. We can discuss in our forum. Thank you very much. And I think we said 1 hour. We are exactly 1 hour within the time frame that we had set for ourselves. And I think I thank you for even our audience that have been able to join our program. We wish you well and we thank you and we hope that tomorrow you'll join us. And if you have any questions, you can write them on the chat section. The speaker for tomorrow will also be looking at those questions to be able to also give their comment and feedback so that we can be able to carry the fraternity along. So, otherwise, I also thank the panelists that were able to ask some questions and be able to make comments. I think it has been a wonderful evening, and we have also gotten time to learn something. Thank you very much.
Thank you too, Milan.